Right, I'd like to talk about Alzheimer's disease today. I'm Professor Heun. I spend lots of my time working on Alzheimer's disease, and I'd like to give it a little bit of an overview. Alzheimer's disease is named after the German researcher Alois Alzheimer, who in 1901 started looking at a patient, which was Auguste D., and she was extremely jealous about her husband. She was deluded and lost her memory. And as this was usual at this point in time, after she died in 1905, her head or her brain was examined, and they looked for histological abnormality. And in her brain, they found something which was called amyloid, which is more or less a protein deposition which stains as amylose, like sugar. So this is more or less the start of that. And at this time initially, the name Alzheimer's disease, or what's now called as Alzheimer's disease, was reserved for people who had early onset dementia of Alzheimer type. So Alzheimer's disease, as it's now called in all age groups, is the common cause of dementia in most older people. In most older people with dementia, 70% of people who have dementia have Alzheimer's disease. It's a neurodegeneration, and it shows cognitive and behavioral impairment that is sufficiently severe to interfere with day-to-day activities. It could be social, it could be occupational activities. Less than 1 million or up to 1 million of people, depending on different estimations and definitions of severity. We have in the UK up to 1 million people, and possibly more than 50 million people worldwide who suffer Alzheimer's disease. Usually it was at some point in time was called dementia of Alzheimer's type, because the course of disease is slowly progressing. And it's the other thing, it's mostly affecting the memory. Okay, so the fact is that, the number of people increasing simply because more and more people in the developing world or in the developed world are getting older, and the age group where it's common is getting bigger and bigger. Right. Usually, most people, when they get older, have a risk of Alzheimer's disease. At the age of 60, the risk is 1%, and it doubles every 5 years. And in the risk in people aged 85 and older is 40%. Usually the incidence, so that's the prevalence coming in a specific time, or new prevalence in a specific time, is the same for men and women. However, there is excess prevalence in women, which is usually explained by the fact that women live longer. Usually the people survive between 5 and 10 years, but many people, depending on when the diagnosis was made, will be dependent on many of the activities of daily living within 5 years or so. Okay, risk factors are age, as I told you. People with Down syndrome have a higher risk of amyloid. There's a genetic factor, which is apolipoprotein E, E4. This specific allele increases the risk of Alzheimer's disease by doubling it. Diabetes is a risk factor, smoking, and hypertension in middle age. Protective factors are rare. Some people have the specific apolipoprotein 2, E2 allele. What is also said that a high level of primordial education and functioning is preventing dementia. However, it seems that there is more protective factors, and the diagnosis is done later. So it's not totally clear whether it really prevents the dementia, but if it comes, it might come faster then. Right, so physical activity in middle age, possibly by improving the blood flow to the brain, is helpful. And there have been some studies showing that non-steroidal anti-inflammatory drugs, such as aspirin, might be helping with prevention. They initially found it with people with rheumatoid arthritis who got lots of anti-inflammatory drugs, and they had a reduced risk of Alzheimer's disease. Right. As I said, genetics is an important factor. The ApoE4 allele, which is on chromosome 19. This is a gene which is in 15% of Europeans. First-degree relatives of patients with dementia have an increased risk. And this is something I have been doing large family studies in the 1990s with, and we later looked at the genes. Right, there's some other genetic factors, such as presenilin 1, presenilin 2, or amyloid precursor protein on chromosome 21, which also increase the risk of Alzheimer's disease by affecting the metabolism of amyloid. So what can you see in the brain? I think initially I said, Alzheimer examined the brain of this patient with today, and he found amyloid plaques, which are insoluble amyloid staining plaques. They're peptide deposits, and at some point in time, they're beta-pleated sheets in the hippocampus, amygdala, and in cerebral cortex. And the density is higher in advanced stage. There's another abnormality, which are neurofibrillary tangles. They consist of phosphorylated tau protein. Tau protein is a protein which is more or less stabilizing in individual cells. So it's part of the usual cell metabolism and ingredient. So these tangles are then found in the cortex, hippocampus, and in the substantia nigra. There was a long discussion in the end of last century about what caused the dementia. Is it the amyloid, and is it the tangles? And they sometimes gave themselves the amyloids and the Taoists. But anyway, it seems to be that both is important. Right. Okay. The other thing is that this deposition of amyloid plaques and tangles leads to a loss of neurons, and possibly this is what is most related to the clinical effects. Because if you have atrophy in the hippocampus or reduction of cells and synapses in the hippocampus, then the function of the memory will be less. There's also a little bit of a cholinergic hypothesis, simply by the fact that if you increase the cholinergic system and the acetylcholine in the brain by acetylcholine esterase inhibitors, which is one of the medications, we can come back to that later, then you can reduce the effects of the Alzheimer's disease, at least for a couple of years. So this effect of the acetylcholine esterase inhibitors more or less led to the cholinergic hypothesis. So for what do you need to confirm a diagnosis? First is you take a history and you have a physical examination. More or less a physical examination should include other physical health problems, such as major vascular problems or vitamin B reductions. So usually what we want to find is to see whether there are treatable causes of dementia. I can come back to this at a later time. Usually then you do some cognitive testing. The most common is the mini-mental status examination, which was published by Fulstein in the 70s. Other use in MOCA or the ACE, which is the Edinburgh cognitive examination in different versions. Usually one should have a CT. The other, if people have Alzheimer's disease, they should show some cortical atrophy, and usually it's focused on the parietal and temporal lobes, and the MRI shows it slightly better with more precision, and they can also look at, so more or less CT and MRI are anatomic investigations. They say nothing about the function of the brain, but when you do SPECT, you can show some increased or reduced blood flow, and in Alzheimer's disease, you see the reduction in the temporal and posterior parietal cortex, which is under-perfused or hypo-perfused. You can also use some glucose markers with PET. We call it fluodeoxyglucose PET or FDG PET, and it shows a reduction in the metabolism in the temporal and parietal lobes. So what are the clinical features? In the early times, I said this: poor memory, disorientation in time. Disorientation in time because you always have to update the memory about, what time is it today, tomorrow, and yesterday. Struggling with activity of daily living, might be cooking, might be cleaning, disorientation in space, changes of behavior. People are more wandering around or more irritable. And usually when people present to the doctor, all the cognitive deficits are there. In middle stages, you have a general cognitive deterioration. You can have aphasia, where people have struggling speaking, apraxia, where people have struggle using their hands, agnosia, where people struggle to recognize things, so it may be that they don't recognize their children or their family on family pictures, which are in their living rooms or bedrooms or wherever. So they're impaired visual spatial skills and the executive functioning, like, doing things together, putting, let's say, activities together, like, using a screwdriver, using a key, or using whatever complex mechanical system might be disturbed. In late stages, people are physically deteriorating. They might be incontinent. The gait is disturbed. People might be more spastic. Seizures are more common. There might be a tremor, weight loss, loss of appetite, and some primitive reflexes, such as the Babinski reflex, might be more prominent. In some cases, the Alzheimer's disease is a bit more difficult to treat because people have behavioral problems. They might be paranoid, seeing things which are not there, seeing animals in the house, having auditory and visual hallucinations, which in whatever, up to 10-15%. They might be more depressed, and they might be more aggressive, have a very difficult temper. Some people have a sexual disinhibition. I have had patients who use the bins as toilets. Some people eat excessively or have no appetite at all. I'm not sure whether clinical subtypes are the major problem. I think one should be clear about the fact that there is also a big variations in the symptoms of Alzheimer's disease. So some clinicians explain different types of variants, which looking at the areas of the brain which are most affected, such as memory or language, or visual spatial functions, which are more located in the occipital parts of the brain. So these are the different types of Alzheimer's disease. You can have some where aphasia, the speech is more influenced by let's say, Broca type aphasia, where people are unable to speak, or Wernicke type aphasia, where the speech is active, but the speech makes less sense than before. So this is our first part of the Alzheimer's disease lecture or explanation. If you are interested in further information about mental health problems, please subscribe to our channel. Okay, thanks a lot, and I hope you had some good understanding of that. Okay, goodbye, and thank you very much for your listening.